Hello and welcome to episode 9 of the Auditing Antics podcast. So today we're going to be talking about the routine waiver of copays, out-of-pocket costs. This can come up in a lot of different ways. And, when we start to break it down, and even as we were prepping for this episode, it does seem like there's a lot that goes on surrounding this. So I'm going to make sure today as well that as we talk through different specifics, I'm going to read some passages, I guess, from different documents related to the payers or, legal, all of those types of things, because I want to make sure that I am getting this out correctly, because there is so much misunderstanding about this particular, process that people go through and just think they can do essentially whatever they want. So to begin here, when we're talking about this routine waiver, what we're talking about is different practices that will go in and, not bill a patient for any out-of-pocket cost. Maybe they advertise stating that, you won't have to pay out of pocket, but yet we can also see that there's insurance that they take and they plan to bill to insurance, but not collect from the patient. This can also be an issue if there are different discounts that are being applied either normally to services, but products can be an issue as well. So as a whole, if there is a situation where that on a regular basis, there's, certain family and friends that never have to pay out of pocket, maybe professional acquaintances. There's times, for example, that I'll do a or I'll do an audit and I can see that they've treated somebody and it's one of their friends from a practice down the road, and we start to talk about it and they'll say something like, oh yeah, that's my friend, I'm not going to charge them out of pocket, they don't charge me, or they refer patients to me, so I don't charge them when they come here for their treatment. And, I do want to say we're going to focus more today in the medical side, but this is also a huge issue in the dental industry. That definitely happens a lot, especially with referrals and, not wanting to charge your friends and whoever it may be. So this is really going to be applicable across the board, regardless of your relationship to that person that's receiving those services. Now, as we break this down today, we're going to look at this from a couple different perspectives as far as the entities that take issue with this, right? So the first is going to be the payer side. And this is something too, Michelle, I actually find that when I work with clients, they don't realize that this can be something that, number one, is violating their participating contract with that payer. And we're going to go over an example today. I have a current client in case I'm working on, and the insurance company is also holding the patient or the customer responsible for paying their out-of-pocket and saying that it's against the patient's policy agreement to accept, these routine waivers or forgiveness of out-of-pocket costs.
Yeah, I think that a lot of times people don't even know that by doing these things it's being violated, and there's all sorts of circumstances that we'll touch on today where it could be a violation in your involvement in a violation of the False Claims Act. And even if it's unknowingly or you have good intentions, it's still a violation. I think that's something to think about. A lot of times when we're talking about waivers and things like that, it's not always related to a friend or a family member. You think you're doing something kind to help out a patient or, something like that, or to avoid confrontation. And
that's a big
unfortunately, it's a violation. And a lot of people don't understand how that plays into all of this and why you can't do it.
Yeah, and that's something too, if you think about it, and I've seen different advertisements. I live here in Knoxville, Tennessee, and I've seen advertisements from, say a chiropractor, or there's a lot of hydration type, infusion type practices popping up now. And they'll say, oh, come in today and you'll receive free hydration. But then also looking at it, it's sending mixed messages because they're also showing the insurances that they participate with. And me being someone in the industry, when I see different advertisements like that, you can't piece through just from that information to understand if they're offering that, just free of cost. Like, okay, here we have all these infusions, come in and get one. Or if they're billing the insurance company and then not charging the patient, and that's why it's quote unquote free to the patient. So those types of things are going to be really problematic. And, that's something too that I think a lot of practices don't understand is the advertisement side and what that looks like. That's also another example as to why it's so important in general in medical practices to have legal counsel. We're going to talk a lot about this somewhat from the legal side today. That's not my particular training necessarily. I do a lot of work in that space from an expert perspective, but it's really important to know the legal input side of things, because as we talk through this, you're going to find that sometimes it's not only a compliance department, for example, that you need to go and talk to. It's either your internal or external, counsel that needs to really weigh in and make sure that you're checking everything before you just make these decisions and, try to do what you want to do with the practice and really with the whole revenue side of everything. And, I just want to go back really quickly to the point that I made about the contractual obligations. A lot of times when I'm working through audits and find variances, there are direct ties back to a participating provider manual or agreement or existing policies. And a lot of times, again, people are not realizing that these obligations exist. So it's important to have someone in the organization somewhere, should really be a provider if they're signing off on it, but it's important to at the very least read over your participating manuals for all of your payers, and then also from the perspective of the contracts, looking at that. Now, one thing I will say, and this is going to come up today as well, there are also going to be times where the patient can be affected even if you're out of network with the insurance. So there's really a lot of, stop gaps and brick walls here that you're not going to be able to get through legally or compliantly, unfortunately. Now, one thing I want to cover first, so talking about, the payer perspective and fee forgiveness, we also have to look at it from the perspective of the government, from the legal side, from the laws that are in place, and all of those types of things as well. So from the perspective of HHS, and this is something I'm just going to read through quickly here, the routine waiving of copays could implicate the AKS, so that's our anti-kickback, and you may not advertise that you will forgive copayments. However, you are free to waive a copayment if you make an individual determination that a patient cannot afford to pay or if your reasonable collection efforts fail. It is also legal to provide free or discounted services to uninsured people. So I say that because I want to throw in a caveat at the very beginning before we dive into specifics. And that's really related to the fact that, yes, you can do those things, but there has to be specific policies in place. There has to be consistency, knowing that you're applying it across the board in the same way with the same methods and criteria to all patients. And that policy is not going to then be your, free ticket to still continue to routinely waive these costs. Now,
I
Michelle,
think the key there, Stephanie, is consistency. You can't just have these policies in place and then on an individual basis decide who you're going to waive things for and who you're not going to. There has to be a standard process in the place that applies to everybody. Like you said, reasonable efforts to collect. You've determined financial hardship. So it should never just be, oh, we're going to waive this because this person's mad or this is Dr. So-and-so's friend. We're gonna waive this for them. There has to be processes in place to show that you've done your due diligence. So I think the key in all of this is consistently and applying it consistently across the board.
Now, Michelle, I want to talk about a case I'm handling right now, but before I do that, can you talk a little bit about your experience, even, from the perspective of being a coder or an auditor and educator, and what this can look like in our roles when, we have providers coming back mad at us. And, depending on the entity you work with, and believe me, I know because I've either been involved as an employee or externally as a consult, but sometimes entities will put physicians on a pedestal from the perspective that they make decisions regardless of the compliance implications. And that's always really hard to work with from our side of the industry. And it's hard, especially, let's say, for example, if you're at the level of a production coder and you're being put in these situations, you feel like these people are above you, they're in higher positions, you don't have a right to push back. So can you talk a little bit about that? Because I know that you've experienced this as well.
Yeah, so one scenario that comes to mind immediately was back in the early parts of my career. I was working with a new gastroenterology nurse practitioner. And one day she called me because she had been doing her inpatient rounds, and she went and she saw this one particular patient. She came back, completed her documentation, and then the physician that was rounding, that had come in behind her and was rounding afterwards, taking over her service, saw this note and called her and said, this is Dr. So-and-so's, I'm not going to use their name, mother. And out of courtesy, we do not document these visits or bill her for these visits. So she had called me and she was like, I don't feel right about
document
this.
or bill both?
Yes.
Oh, man.
They were like, we just pop in to see how she's doing. And the really interesting thing is, how do you order treatment? How do you put a treatment plan in place? If you can just pop in and not have to document anything, I guess you didn't need to treat her for anything. But this nurse practitioner, she called me really concerned, and she's like, this is somebody, I don't want to step on any toes, but they're telling me I shouldn't be doing this and we shouldn't be billing her. Is this correct? And I said, it absolutely is not correct. I said, if you have a patient encounter, you need to be documenting that encounter and billing correctly for that encounter, regardless of who that is. And I explained to her, in her note, I read her note, she was initiating treatment for this patient. She was ordering tests and she was putting them on a medication, and just had to give her reassurance that regardless of what your colleagues say or who this patient is related to, you absolutely need to document and bill appropriately for those services. And it made her feel a little bit better, because she kind of felt like, oh man, I'm the new person in the practice. I'm going to upset people because I'm billing this person's mother when nobody ever does. And she wasn't wrong in this instance. And there's just so many things wrong with that particular scenario that, that arose as her questioning that. And I say good for her for questioning it. How often do we get presented with these scenarios? I know you were talking about as coders. I think that's one thing we really have to remember, that as coders, we also can have involvement in violating the False Claims Act. We have to remember that when it comes to the work that we're submitting and the work we're doing, we really don't get a pass for directly violating something just because somebody else told us to do it or we didn't know that it was wrong. It's up to us to make sure that things are being billed in a compliant manner. So another scenario that I think of that I have experienced is related to patient complaints. I know you've probably experienced this as well. You know, there's times when, even when it's a different department that's taking those patient phone calls, at one facility that I worked at, they would take those patient complaints, they would forward that to us as the coding staff or somebody who oversaw that particular department and oversaw their compliance, and ask us, was this billed correctly? So we would review the documentation, reviewed what was billed, and we would send it off to them if it was billed correctly, if it was billed incorrectly, what should have been billed. And then in some cases, they still chose to write off that service, even if it was documented and billed appropriately, because the patient was upset. And they, you know, you have to follow consistent practices when you're looking at things like that, because maybe this, you know, E&M along with an annual wellness visit, sure, that's easy enough to write off, even though it might be supported. Whereas this person's colonoscopy has been, you know, billed correctly, but it wasn't explained to them the difference between preventive service and diagnostic services, and now they have a bill, and they're probably not gonna waive that colonoscopy. I don't know if that's a good example, but it has to be across the board. And you know that when situations like that are coming up, it's not being applied across the board. You know, a factor of it is how much was this service actually, and things like that. So you have to be sure that you're vigilant. And from a coding perspective, I know I've worked a project before where we were having somebody at the facility review our coding, and it seemed like day to day their opinion of what we were coding changed. And then finally one day it came out, and this reviewer said, well, I know it costs the patient more, so we just down code the service so it doesn't cost them as much. And from a coding perspective, and being a coder, if that is something you're doing, if you are down coding, or maybe you're coding an E&M instead of a procedure because you know it's not covered, that's a violation. And you need to make sure that you're not having involvement in that. And if you're being asked to do that, you need to speak up, and you need to tell them why that's not correct and why you won't be doing that.
Yeah. And, you know, I've had things like that come up in audit reviews as well, where I will go through, conduct an audit, and, you know, there's one patient who's billed like 2 levels lower. And we'll go into the audit education session, and the provider's like, oh, I don't know why I got this wrong. This shouldn't be wrong. That patient was self-pay. And then I go back and talk to a manager and say, okay, well, what is your policy for self-pay? Do you have a hardship policy? Do you put the patient through, you know, a vetting process to see if they qualify? And, you know, either the practice as a whole has incorrectly implemented something that's not compliant, or maybe one practitioner themselves chooses to do this. You know, I also had another situation where the practice, first of all, again, sometimes these examples include a lot of things that are not compliant, even though we're talking about one. But the practice had multiple different providers, and they did not want to have to do a Medicare wellness visit. So they said, okay, well, we don't do those. Only this one practitioner does. And they saw me. So I did a physical, but their insurance doesn't cover a physical. So I billed it as a level 4, or I bill it as a level 5, because they know they'll just have, you know, routine out-of-pocket costs at that point. So, you know, there's many different ways that this can present, but it also shows why it's so important to have this as a conversation. You know, I think about the larger hospital facilities, and I had the same thing you described, Michelle, because when I started out earlier in my career, I actually worked in a hospital. Basically, I call it a customer service department. So it was billing, it was collections, it was helping patients work through denials, all of those things. And, you know, that can be very common, that there's just write-offs because somebody calls and is yelling and is mad, even though all the services were rendered and all of those
Mm-hmm.
things. So it's really important to make sure that if you are in a large facility, that it's not just compliance that knows this or just the coding department. What about your AR department? Do the billing staff that work that back end of your revenue cycle know that there's different things that cannot be done based on, you know, what we're talking about today? So I think it's funny too, the other example you gave about really pressure that people put on staff, because that
Mm-hmm.
physician put pressure on the nurse practitioner who then was calling, and luckily it wasn't you being pressured by that physician, but I know that can happen quite a bit. Now,
Yeah. One
I
one thing I would
go ahead.
like to add in there is a lot of times when I see these circumstances where these violations are happening, it is um, policy or, you know, workflows, we'll call it, that have been put into place, or administration has sent something down, or like you said, maybe providers in a practice have decided this is a good idea, and there has been zero involvement from compliance. And it's not until after the fact that compliance figures out what's going on. So I think a lot of times facilities don't even think to say, hey, maybe we should get the input of compliance. So like you said, it's very important that compliance is making sure that the right people know about these things. And you know, sometimes I think people are like, oh, they don't want to hear from us, or they get dismissed enough from administration or practice manager or things like that. But you really have to make sure that you're getting that information out there, that they're aware of the compliance risks, or even just aware that when you're making a change to a workflow in the practice that is related to payment, related to coding, related to adding services, before you do anything, you need to contact reimbursement, and they need to be involved in that process wholly. Because one, it could save a whole lot of time if from the beginning somebody can tell you this is not compliant, and you now don't have to do all this work of implementing a change to your practice workflow for something you're not going to be able to do anyways.
Yeah,
But
definitely.
unfortunately, compliance seems to be the last to know.
Yeah, that's very, very common. Now, I had mentioned I have a current case that I'm working on. So what's happening with that is there's a practice, and I'm not going to give details other than the fact that this involves the payer Cigna. So there is a practice who has a lot of things going on, you know, that they're working through in their current review and investigation. But one thing that I found really, really interesting in this particular case is the fact that the correspondence from Cigna is specifically laying out and identifying the issues with fee forgiveness. And they're talking about this being an issue for in network, and also if you are an out of network provider. And I think that this is very important to highlight, because a lot of times, again, you know, people have skewed ideas on what's compliant, what's not, or, you know, what their friend does and get away with. That happens a lot. And a lot of times I will talk with different people and they think, oh, well, you know, I don't participate with that payer, so I can do what I want. I don't have to listen to their policies. I don't have to listen to their rules. You know, I'm not in an actual participating contract with them. But we have to remember a couple of things. And I'm not going to dive too much into this today. And there's different legal, you know, sides and arguments that can play into this as well. But there, to an extent, is still an agreement in place when that practice chooses to send out a claim for the patient. So there are going to be times, for example, I take my family at times to a particular clinic in the area, and the nurse practitioner does not want the hassle of the rules and restrictions within the insurance industry. So they will help you get the information you need, but they will not bill the insurance and they will not submit the claim for you because they don't want any part of it. So even if you don't participate and you want to be hands off, to some extent, you still have these obligations if you are choosing to send that claim out the door, which is usually the case even when you're out of network. So getting back to the Cigna situation. So what was interesting in this, and I'm not going to read the whole thing, but what they were calling out in their basically educational letter back to the client was the fact that when there are these routine fees being forgiven, this is not only against, the provider will say, but they actually have their members or their customers or your patient sign off on specific forms. And I had found this form online actually from Cigna. It's called an out-of-network referral disclosure form. And inside this form, it has specific detail for the patient where the patient has, a notice that is basically given that they have to sign off on as a part of, taking services from this out-of-network provider. So this, I am going to read this part just because I find it so interesting. So inside of this, it's a section that says it's for the Cigna customer out of network, and it's their informed consent. So they're informed and they're aware they're receiving out-of-network services. They're agreeing to this and they're signing off on it. And it says please take note of this important information about fee forgiving or waiver of charges. Some non-participating providers and healthcare facilities may offer to fee forgive your charges by adjusting the amount you pay to use their services. They may tell you that they'll accept payment based on what Cigna pays for participating providers. If you accept this arrangement, you may need to pay out of pocket for the services you receive and be responsible for submitting the claim to Cigna, which they may or may not accept. Cigna's policy is to prohibit fee forgiving or waivers of charges by providers using all of the contractual and legal obligations available. And then they go on to say, if you are being offered fee forgiveness, here's our special investigative unit hotline. Please call us and let us know. So the patient has to basically check these boxes, attesting to the fact that they've read it, they understand, they agree, and they have to sign off on it, saying that they're not going to participate in that type of behavior, really, with that payer. So the reason I found this so interesting is because all of the different cases I've worked on, it's always been this big focus on the practice, right? Obviously, it involves the patient or that member or customer of the payer, but there's always that large focus on the practice and their wrongdoing. So I just found this very interesting to see that there's, documents out there, which, even a basic level of understanding is a lot of times difficult for our patients anyways, right? We've talked some on this podcast about how important it is to understand your coverage, your out-of-pocket costs. So to me, even going as far to know that this form exists, and not only that, within their education that was sent back, they cited specific cases that they were, that they won, essentially, that went to court where their form was upheld. So to me, this is just showing, how deep it goes from the payer side before we even talk about the legal side, how much that they are looking at it. In this situation, they were doing an audit of this practice for different reasons, but yet they were still able to uncover this.
Yes. And I find it very interesting that they give the patient a phone number to call, basically report this happening. If you think your patients aren't going to call and say, hey, this happened. I mean, some probably sign that, don't even read it, don't even know it's there. But then we all know there's those people out there who have to read every line of something that they are. So I wonder how often it's uncovered because it's patient reported. I mean, remember, the patient can call insurance and complain about anything. I can
Yeah.
remember years ago when my husband was going through a pretty major health situation. We ended up having to call the insurance to get results at the doctor's office to basically, because they were trying to blame it on insurance, and that wasn't the case at all. And after that, he had a weekly call with a nurse practitioner from the insurance company asking about different things that that were being billed for him. So, I mean, there was some pretty close follow up on that, but I do know the care in that situation was pretty costly. So I'm sure they were wanting to make sure everything was covered. But they have people who reach out to the patients and they ask them these questions. Patients will call if they're dissatisfied, and they will tell them exactly what's going on, and things like that. So you have accountability from that avenue as well.
Yeah, and one thing that people really don't realize as well, and I just had this conversation recently on another case I was working on. A lot of people in the industry don't even understand that when these investigators are involved, they can reach out to the patients. That is their
Mm-hmm.
member. They can, if you are treating patients, and I know this is a little different, but if you're treating patients in a nursing facility, they can put someone physically in there to talk to their member and see what
Mm-hmm.
it is that you're doing. So if they have, any kind of concern based on what they're seeing data-wise, they can open up their investigation and reach out and then start questioning the actual members. So
Yeah,
that's really important to know.
and I believe they definitely do that, because the patient doesn't understand from. They're just going to tell you what's going on. I mean, in my case, we were we were quite aggravated. To be honest, it was past being upset. We were mad about what was happening. Nobody was listening. Everybody was deflecting. And we finally called the insurance and said, "This is what you're paying for, FYI. What can we do?" And and that's how we ended up getting that resolved.
Yeah. Now, going into the legal side, so this is something again that's really important, because even if, you have providers that are pushing back and not wanting to listen to what's talked about from the payer side, we've got to think about the legal side as well. So I had mentioned the anti-kickback statute. So that's one of the things that, we look at that from the perspective of what is a provider basically doing to entice a patient to come over, or to, get some kind of, the word kickback is there for a reason, to get a kickback for the different referrals they're putting out there. And, how are they gaining something from what's taking place. So when we have especially things like the professional courtesy, I hear that a lot. I'll talk with maybe a practice manager after an audit, or, actually another time this comes up a lot too is when I do revenue cycle management reviews. So when I'm looking at the whole picture beginning to end, digging into different reports, seeing what's being written off, all of those types of things. That can be very clear as well, because as we said in the beginning, you still have to make the proper efforts to get that payment from the patient. So if it's immediately being written off the second you receive it, and or payment from the insurance, your adjustments not matching the remittance letter from the payer, then it's going to be very clear to anybody looking at that data that that's not accurate. So especially with the professional courtesy, regardless of your specialty, like I said, dental, this is a big issue. You have to make sure that that's not something that you're doing on a routine basis. Now, the other thing too is when we think about this from the patient's perspective, I had said there that sometimes patients will be enticed, or like those advertisements that we see. That's why it's so problematic. You are pulling the patient over in that direction to receive that service. And, hopefully they're receiving good care, but sometimes it's not always tied to the best care, especially when somebody's focus is highly on the money side. But all of these things can be traced and can be found. So to think that you can just do this inside of your little practice or inside of your, hospital organization, it absolutely can be found as soon as anybody starts looking under the surface. Now, the last area that I want to cover from the legal side is the False Claims Act. So I was reading this particular article and I want to call them out and I want to speak about the example they gave because I thought this was perfect. The problem with the False Claims Act is that the insurance, think of it this way, the insurance is not getting the same discount that you're giving the patient. And that
Yes.
ultimately is going to be the problem there. They don't want you to discount services for the patient, but then pay them or charge them full price. And, again, a lot of people think, I'll just collect what the insurance gives me and I know that that'll be good enough, right?
Yeah.
Now, with this particular article, this was with an organization, it's the Whistleblower Law Collaborative. And they have an article out there about all of this, related to the legal side of the routine waiver of out of pocket costs. So they gave this particular example in their article, and they said, think about it this way. So our actual charge to Medicare is $100. And based on Medicare's fee schedule, they're going to pay $80 and the patient has a $20 copay. So at the end of the day, that full charge, the 100, or we could call it, the allowed amount is a better way to say it, that's still being reimbursed out between the coverage and then the patient out-of-pocket cost. So if that practice continually writes off that $20 because they think it's better to just gain that 80 on every patient, that becomes problematic because now that charge has been inflated to Medicare or to the payer. So for
Hmm.
example, if the provider has no plans of collecting $20 from the patient, then Medicare is going to look at that they should be paying 80% of what they're collecting or expecting to collect, which would be $80. And that would be a cost of 64 instead of a payment of 80. So, that's just one example, but that is why the insurances and especially the government have such an issue under the False Claims Act, because you're not applying the same process or the same, adjustment or courtesy or whatever word you want to
Hmm.
use. You're not applying it to the payer, and they want that same courtesy that you're giving to your patients, even though everybody, in these practices are thinking, oh no, the insurance company doesn't need any more savings, but in their eyes, this is how it works.
Yeah. Yeah. I think that's something right now that's kind of like a soft subject or a difficult subject with the insurance company saying, well, if
Oh
you're going
yeah.
to discount for the patient, I'm entitled to a discount too. And when you think about it, removing everything, that would be only fair. Why should they pay more if their patient isn't being expected to pay?
Mhm.
If the patient's getting a discount, they should too.
Well, and yeah, and I think that this goes back to the main point of the episode too. We're talking about the situations where this is done on a regular basis.
Yes.
And, getting into the final part of the episode here about, policies and what you're implementing inside of your practice and organization. As a part of one of my revenue cycle reviews, I had a situation that was very frustrating because the practice had attempted to implement some policies around this, right? They didn't quite get there, but they tried. And it was a dermatology practice, and they had decided as a group, this was one that, does have the heavier input on the physician side with a physician owner, a board. If you have any dealings on the compliance side or education after an audit, that sometimes that can be a little more difficult because you have more clinical pushback in that situation. They're looking more on the financial side as well. At times, not everybody, but it's very common. And in this situation, what they did is they had a policy that basically said if the patient has an open balance, they cannot schedule their next visit. Well, the problem is that we're dealing with dermatology, and not to mean that this wouldn't be an issue for everybody, but it's dermatology. You have patients with history of, different types of malignancies, and they need to have their different checks, or maybe even, they had one procedure done, with pathology, it confirmed that, and this actually came up in my review. There was pathological confirmation of a malignancy. The patient needed to be coming back in for a more extensive surgery, like we'll say Mohs surgery, for example. But they had this policy in place that if there was a balance, they couldn't schedule. So, from a malpractice standpoint, or, you think about medically abandoning a patient. Again, I'm not legal, but my mind still goes all of these particular places.
Yeah.
And the one thing that the one physician was doing, because he was upset with the policy and he was pushing back on the practice, is he refused to charge any of his patients out-of-pocket costs. So all patients for one provider had everything written off after the payment from the insurance so that they could get back into the practice as they needed for their medical care. And that is a huge example of where there can be all of these disconnects when people are not looking at the whole picture. And again, we're talking compliance, but you've got to have legal input appropriately as well. And not just from your HR employment attorney, you've got to have a good, solid healthcare attorney. And, there's a lot of them out there. I work with a lot of really good attorneys. Sean Weiss, obviously, he has a lot of contacts as well. If you ever have questions, reach out and ask, because there's lots of people all over the US that practice in, all of the states that I could definitely refer you to there. Now, Michelle, from the policy perspective, thinking about what it is that needs to be in place, do you have some input there about, what a practice should look at if they're coming together to put this policy together? What are some of the things that they should be looking for and, capturing as a part of that process?
So I think that when they're looking to implement these things, to have consistency in their policy, there's certain criteria that they should put in there for establishing, for example, hardship. What criteria are you going to put into place to show this patient has some type of financial hardship? It could be income related, what are poverty levels, family size, things like that. And then you want to have some type of documentation in place where you have supporting documentation that is going to be required from the patient to go along with that application process. You want to make sure there's transparency and consistency. And also, like you said, make sure you are consulting with legal counsel. I think it's really important that when anything like this is being implemented, I think based on our conversation today, it's really evident that you need to have all parties at the table. You need a clinical opinion, you need a compliance opinion, you need a practice workflow opinion, that administrative financial opinion. Everybody has to come together and make sure that all of those boxes are being checked. But so importantly is having that legal counsel in there as well to make sure that it's compliant. But I do think there's something to be said by having somebody from every part, because when you think of that policy you were just talking about, not being able to schedule a patient when they have an outstanding balance, what kind of a perspective could that provider have given to that conversation before that policy was put into place to say, listen, as a provider, I have requirements, I have obligations to my patients that have nothing to do with us getting paid for this service and everything to do with me taking care of my patient, ensuring their health and their safety. And I know
And
that
their medical license.
yes. And so I think there's, there's something that comes from having all perspectives present and having every single facet of that represented so that we can make sure that in order to put this into place, we're not considering this provider's legal obligations as well. And I think that sometimes, from a compliance perspective, we're like, we think about compliance and we all get our blinders on. Administration's thinking about finances, the providers are thinking about their clinical patient care, we're thinking about compliance and what's allowed, and we all kind of get these blinders and we forget that we need to come together collectively. And within organizations, if you're part of administration, you're a practice manager, and you're having these conversations and you're not getting input from every single facet, I would really encourage you to broaden that horizon, because boy, will it save you a lot of time and hardship when a policy such as, won't schedule due to outstanding balances is put into place, and it causes a whole uproar. Because I can tell you, if I was a doctor, I know I worked with a dermatologist years ago, and there was that whole possibility about modifier 25 reduction in payment for E&Ms on the same day. And she's like, but I can't let my patient walk out the door knowing they might have cancer. She's like, and they're telling me the workflow process is to just do the biopsy on a different day. And she's like, I can't. She goes, what if the patient cancels that appointment and now they're walking around with cancer? Like, she really was concerned about her patients' overall health and safety and what happened after they walked out that door. And she didn't really care about the payment, but she was getting this pressure from administration because she was one who wanted to do everything all in one day just for her own peace of mind. And so getting that input from that perspective is not always something we're thinking of when we are looking at compliance or finances.
Yeah, and the last piece I want to end with and highlight that you brought up, Michelle, is really that paper trail. Because one of the other things that I find that is still highly problematic is when people do have a written policy, but they're not actually following it. So I had said at some point during this episode, having a policy doesn't excuse the behavior continuing,
Yes.
right? So if you say that you have these specific parameters that the patient must meet in order to adjust whatever in whatever way, then you've got to have that paper trail to show that you did your due diligence, the patient submitted the information, it was vetted, it's applied the same for everybody. It can't just be sitting there as something that exists in a binder that isn't actively being used.
Yeah, and
So
only sometimes, having the patient go through this process
yeah,
versus
picking and choosing.
every patient that you're considering doing some type of waiver for goes through that process so that you can show consistency across the board.
Yeah, and with this, I think one of the main things too is the hardship part. This isn't a courtesy policy,
No.
it's a hardship policy. So just because you have a hardship policy doesn't mean that your doctor friend down the road and his wife can come in and not pay anything.
Yeah.
So we have to be really careful about how that's going to be applied.
Mm-hmm.
So we'll go ahead and end the episode there for today. And if you have any questions or if you want to reach out and, get some referrals, I had mentioned the different health law attorneys. Please email me or visit the website, stephanieallardconsulting.com. My email is sallard@stephanieallardconsulting.com. You can also check out the different compliance services that I offer there with audits, the revenue cycle reviews, education, and also the compliance membership that I offer over there as well, if you're interested in having, really a lot of ongoing support in your practice. All right, I thank you, and I hope you all have a good rest of your day.
Yep, and don't forget to like, subscribe, and share.